This is the New England Journal of Medicine COVID-19 update for January 19th, 2022. I'm Stephen Morrissey, managing editor of the journal, and I'm talking with Eric Rubin, editor-in-chief, and Lindsey Baden, deputy editor. Today, we're also joined by Harvey Fineberg. Harvey has long been a leader in public health and medicine. He served as dean of the School of Public Health at Harvard, provost of Harvard University, president of the Institute of Medicine, which is now the National Academy of Medicine, and chairperson of the Carnegie Endowment for International Peace. He's currently president of the Gordon and Betty Moore Foundation and a member of our editorial board. Throughout the pandemic, Harvey has brought to bear his research into decision-making on the important policy questions that the outbreak has raised. And today we want to hear more about his current thinking. But first, let's discuss a couple of pieces that we published today. A few weeks ago, we talked about the comparative effectiveness of the two mRNA vaccines, BNT162b2 from Pfizer and mRNA 1273 from Moderna. The conclusion of the earlier study was that both offered high levels of protection, but the Moderna vaccine was somewhat more effective. Today, we have a study from Qatar, a country that's produced a good deal of effectiveness data, and this study asks a similar question. What did we learn here?
Steve, these researchers tapped into the same national electronic health databases they've used in the other studies to determine the incidence of COVID-19 infection in people who received each vaccine. They matched each recipient according to the week of vaccination and other variables and excluded those who had prior evidence of infection. For each vaccine, they matched more than 190,000 individuals. In those who received 2 doses of vaccine, there were more than 870 infections among the Moderna recipients and 1,262 among those who received the Pfizer vaccine. Very few recipients in either arm required hospitalization, and there was only a single death. The study continued until October of 2021, a time period that included Delta variant infections, but before the appearance of Omicron. The advantage of the Moderna vaccine was relatively stable over time. These results are consistent with the previous work we published, though the very large numbers in this study give us very strong confidence in the results. I'd still say that the differences between the two vaccines are small and that both do an excellent job of protecting against severe disease. But remember, this is not a fully representative population. Qatar has a youthful population, and even small differences in disease severity could be magnified in a place that had a larger number of high-risk individuals.
So, Eric, I think these data show us the scientific process as we approach the asymptote of improving health. What I mean by that is that overall, the rate of severe infection, hospitalization, and death is vanishingly small in both groups. So though differences may be seen, the overall benefit, with well less than 1% requiring hospitalization or having more significant illness, I think is a really important finding. That doesn't mean the scientific process doesn't try and figure out differences between treatment groups and how we can further improve an intervention. And these types of data are challenging, as we've discussed before, because the vaccines were not rolled out at the same time. It was not randomized, so the populations immunized with vaccine A or B may have some differences that are not captured. And the circulating variants challenging the vaccine immunity also change over time. Having said all that, having substantially less than 1% severe illness, I think is the important conclusion and is very informative about the benefits of vaccination, despite time from vaccination and alterations in the circulating strain.
You bring up a very important point, Lindsey, which is the incidence of severe infection. It just was hardly there at all in this study. Now, it is a younger, lower risk population, yet it goes back to a discussion we've had many times before, which is what is the aim of vaccination? Once upon a time, we hoped that it would eliminate disease, but it's clear that transmission can occur, particularly with variants like Omicron, even among vaccinated individuals. And our goal, therefore, has changed a bit in that we're aiming to prevent severe disease and death. And there, the mRNA vaccines are very highly effective.
So, Eric, it does ask the question, at what point do we change from an epidemic severe illness mindset to more of an endemic background cold? And as we've discussed before, there are 4 circulating coronaviruses that we've all been dealing with for many, many years, and none of us care about because they cause the common cold. At what point will this evolve into that relationship with us? And we'll see, but some of these data suggest that may be occurring, at least in some populations who have background immunity and are not at the highest risk for complications.
I think that's fair, Lindsey. Of course, in order to get there, we need very high levels of immunity. And that can come about because there's a lot of infection out there, which is certainly true in Omicron. And the rates of seropositivity are likely to be very high at the end of the Omicron wave. And it also can come about because there's more vaccination. And the combination of the two hopefully can get us to where we need to be. I still think we need to stress the fact that vaccination is a far better way of achieving immunity than infection, and that we still have a large number of unvaccinated individuals, both in this country and in the rest of the world where there isn't good access to vaccines. So I think that vaccination still remains a very high priority.
I completely agree, but I want to just clarify one point, which is if you're vaccinated and then have breakthrough infection, overwhelmingly, it's likely to be mild and will boost your immunity. So superinfection in the context of background vaccination may not be such a bad thing. However, we need more data to properly understand that in all the populations at risk. It's natural infection in the unvaccinated, which we have really been dealing with for the last 2 years and has caused such morbidity.
The second study we published today addresses the question of how to approach those who've received a single dose of Ad26-CoV-2S, the Janssen vaccine. Other work has consistently shown that one dose of vaccine is less effective in preventing SARS-CoV-2 infection and severe disease than 2 doses of either of the mRNA vaccines. So what's the best way to increase protection in this Janssen group?
The investigators here, who come from the Netherlands, compared the immune responses and early adverse reactions seen in those who received the Janssen vaccine and who were boosted with a second dose of either the Janssen vaccine or either of the 2 mRNA vaccines. Participants had received the initial vaccine dose about 3 months before being randomized, and they got either no boost or boosting with one of the 2 vaccines. They were then monitored for both antibody and T cell responses and for the early reactogenic symptoms induced by vaccination. To summarize a good deal of information, all the boosters raised the level of both binding and neutralizing antibodies, with far larger gains for those who received the mRNA vaccines. The same was true for at least one measure of T cell function. Reactogenicity appeared to be somewhat greater for the Moderna booster than for the other 2, though all the reactions were relatively mild and lasted only for a short time. This is a larger study than we've seen, with more than 400 total participants. But the message is the same. First, all recipients of the Janssen vaccine should receive an additional vaccine dose. And second, these measures support the CDC recommendation that most who get boosted should receive an mRNA vaccine. Of course, everything here are in vitro assays, not real measures of effectiveness. We suspect that these are reasonable predictors of what will happen, but we won't know without more data.
So, Eric, a correlate of protection, that which will tell us which immune response or responses will lead to protection from illness, is a holy grail of vaccine development and is being sought after in this context as well. In general, stronger immune responses are considered more favorable, especially in the humoral or neutralizing antibody compartment. And we all look forward to directive data in this space. What I think we learned from these data, which are all based on an Ad26 prime, and then the boost is varied. So we don't know what an mRNA prime will do. But in the context of an Ad26 prime, it does look like an mRNA boost brings out a stronger immune response, at least in the parameters they measured. So hopefully, as you suggest, Eric, these will correlate with stronger immune responses and protection, which is likely, but not shown in these data.
Harvey, I'd like to get your perspective on where we are from a public health standpoint. Early on during the pandemic, you published an editorial called 10 Weeks to Crush the Curve, in which you argued that a series of measures could be taken to bring the disease under control by the summer of 2020. Of course, those steps weren't taken, and we're still living with the virus. But in looking back to the very beginning and knowing what we know now, would your advice be the same?
Steve, it was 10 weeks to crush the curve in early 2020. Today, it feels more like 6 weeks to avoid being crushed by the curve that we're facing. In that original essay, I outlined 6 core elements for an effective response. And I think there are still elements of each of those 6 that would apply even today. The first element was about leadership. I called for a unified command structure, an integrated way nationally of approaching our response to the pandemic. We've done better in some ways on that, but even today, if you asked even informed professionals who is in charge of our response to the pandemic in the United States, you might get a puzzled, quizzical look, or you might hear a number of different names, but we have not really succeeded in establishing a clear, unified, consistent command structure. Second element I raised back then was to make millions of diagnostic tests available. It's fascinating. This is the week, as we're discussing, that the United States government is at last standing up a website by which any household will be able to order diagnostic tests. So it reminds one of the observation of Winston Churchill that you can always count on the Americans to do the right thing after they have exhausted all the other possibilities. And so here we are now distributing diagnostic tests. But I'll come back to that in another moment. The third element was preparation and ability of hospitals and healthcare workers to be protected and respond. At that time, the big concern was sufficient personal protective equipment. Today, it's about burnout and adequacy of staffing and being overwhelmed at different times in different places. That's the challenge today. The fourth element was to distinguish among the risk groups and those who were exposed, those who were early infected. At that time, there was more thought about the importance of contact tracing, perhaps, and differentiating of those who could be quarantined and reduce the spread. Today, we have to learn more about the kinds of questions that Lindsey and Eric were just discussing, about the consequences of infection in different populations, the responses in different times. The fifth element was public education and public understanding. This continues to be a core communication challenge throughout the period of the pandemic, and it's as true today. But the final point that I think deserves special attention in light of also the articles we were just discussing, learning while doing. This was the concept of how important it would be to stand up a core and continuing research capacity to identify the key questions for management and control of the pandemic, to acquire the relevant data, and to make known those results. I think it is sobering that the reports we heard about come from Qatar and the Netherlands. Much of the relevant information that has been published over the last several years has come from the UK or from Israel or from other parts of the world. Despite the overwhelming numbers infected, the severe burden of disease, the differential response in different parts of the United States, we have not stood up a continuing and core capacity to ask and answer the relevant public health and clinical questions in a way that would provide guidance to clinicians and to public health authorities. So those elements, Steve, that we talked about a couple of years ago have salience even today and looking forward.
Harvey, it's been an interesting process because the epidemic curve goes up and down, and there's a lot of reacting to where things are today rather than planning for where things are going to be tomorrow. And I guess we see that with respect to some of the things that you're talking about. There certainly was an effort to make diagnostics, but as the epidemic curve fell, there wasn't so much of an effort to manufacture and distribute those. And I think the same has gone on to some extent with research, where there have been some platforms set up, but there hasn't been so much feeding into them recently. In addition, there's an extra issue with research, which is a lack of research coordination, so that, especially at the beginning of the epidemic, but still to some extent, many groups are asking the same questions. That may be because there aren't that many options to be testing out there. And yet, we can see hundreds of trials on clinicaltrials.gov registered in advance asking pretty much precisely the same thing, which makes it much less likely we'll get a clear answer.
Eric, you're putting your finger on a kind of core point, which is in research, as in response to other parts of the pandemic, are we practicing business as usual and simply amplifying the ways we've always done business? Or do we envision and understand the current crisis as a stimulus to rethink, reframe, and reinvigorate a way to deal with the problem in ways that we need to deal with it? So in the case of research, yes, there are scores, if not hundreds, of separate research projects underway. But if I ask you to identify the 10 core, most important questions currently facing clinical and public health decision makers, and to identify the coordinated research activity designed to answer those questions, that doesn't exist. We are building up from a bottom-up model, which works very well in peacetime, when the ingenuity, interest, opportunity that arises in different clinical research settings in different parts of the country, in the minds of different investigators, do perfectly well to lead us into some amazing developments and progress in medicine and public health. That's a very different way of conducting business than a concerted, planful, organized, coordinated effort to ask and answer in real time the questions that need to be dealt with. I'll give you an example in public health. We are all lamenting the reluctance of many people, too many people, to become vaccinated. Where are the studies that look systematically at different communication strategies, different ways of reaching people, different forms of incentive systems, different forms of requirement that will give you evidence of what does or does not work to lead people to get immunized? We don't have that in place. We should. We talked about the lessons that still need to be learned about the course of illness amongst those who are infected after having been immunized. Where are the databases that are looking systematically at those natural histories of disease, so that in a matter of 2 months, for the near-term effects, we will have those answers. And in a year, we'll have a lot more knowledge about the very worrying effects of long-term COVID. And when it comes to other aspects of dealing with diagnostic tests and coming back from infection, we're in the midst of a very controversial recent recommendation from the Centers for Disease Control and Prevention that basically says if you've been infected and you're asymptomatic, after 5 days without testing, you can return out of your home isolation and return to the workplace, etc. Many of us think that if you have been infected, you should be tested at day 5. And if your antigen test at day 5, your rapid test, remains positive, why is it prudent at that moment for you to return to the workplace or to outside the home activity? Would it not be more prudent to wait either another 5 days or until that test turns negative? Now, you could say it's an arguable point, and it is. The point I am making is if we have a systematic study that looked at viral isolation, PCR, antigen tests, symptoms over time, in a cohort of patients that were infected, in a matter of a few hundred patients and a few months, we would have knowledge that would guide these decisions in a much more definitive way. So it's the gap between our readiness to do the real-time learning and the need for decisions that creates a dilemma for us and is a source of constraint in our ability to overcome the pandemic today.
Harvey, I agree that systematic data are critical to inform our decision-making, our policies, the care we provide patients. And the way you frame it makes complete sense. However, I'm mired in the day-to-day interactions with healthcare systems, regulatory review boards, IRBs, different countries and data systems. The UK has a different system than Israel, than in the US, which is a much more decentralized healthcare system. So though what you say makes complete sense, pragmatically, are we just set up in a chaotic format globally?
Yes, we are. That is, it's not a designed, coherent, or systematic approach to data. But if you just take the US, Lindsey, it's even more kind of fundamentally problematic in that not only do we have the disparate centers providing clinical care, but on the public health front, you really have a federal system with state-based authorities, state departments of public health, which have typically strong legal authority apart from one another and apart from the authority of the federal authorities, particularly the Centers for Disease Control, to actually guide or direct any of those activities at the states. It's more on an advisory function. And this is a part of the challenge of converting from, if you will, business as usual to critical needs and response. And so you don't need to mobilize the entire research establishment of the United States, much less the world, to answer these questions. You don't need to make certain that every last dot and letter of the regulation in every state is exactly conforming. But in the research arm, you do need to have established in parallel to the existing structure an overlay that can be mobilized systematically and selectively to get the answers that we need. You do not need to track every patient to get the answers to these questions. You need a well-designed study managing the data in a relatively small number of patients. And that we should be able to manage over and above business as usual.
Because I think, Harvey, that is one of the lessons learned, is how are we organized to most efficiently advance knowledge? And there are many things that I think went quite well, given the number of treatments and diagnostics we actually have available at 2 years. And there are many which have been chaotic. And I think we as a community do need to take a hard look at what kind of structures we need to put in place so that we can be more effective in advancing knowledge.
I agree with you completely, Lindsey. I think, for example, on the diagnostics, the RADx program that was funded by the Congress and pursued at the NIH in a very, very concerted and successful way, which looked basically at a venture capital model rather than, investigator-driven model to introduce the incentives, the guidance, the support, and the continuing interaction that would take you from a good idea all the way to product. And that kind of so-called Shark Tank or funnel approach to the development of new approaches to diagnostics has been, I think, a very important milestone for both the NIH and for scientific development in the US, and is a great example of what you're talking about. We need more such learning opportunities. We need ways of looking at the public health questions as well as the clinical questions. For example, with diagnostic tests, the ability to use diagnostics in wastewater to monitor the appearance and scale of new viral types as new variants will emerge is another very interesting, important, and useful tool that's come out of the lessons of this pandemic at the public health level.
And Harvey, building that, in part, the wastewater monitoring was developed associated with polio control and elimination, and how that type of scientific foundation can then be exploited in this type of global health public emergency is terrific to watch.
Your point so well taken, and it raises a larger question about the importance of prior research and fundamental scientific research that provides the underpinnings for contemporary solutions. So in the case of the mRNA vaccines, you can trace back lines of research over decades that provided the foundation for making those incredibly successful vaccines possible in response to this pandemic. And similarly, learning from previous epidemics or outbreaks and ways of monitoring, ways of responding would have been very successful if we had had a similar foundation of extensive knowledge on the social science of vaccine acceptance. We would have been much better prepared to enable more people to accept this vaccine. And if we do it now, we'll be better positioned in the future to get the levels of immunization that will provide more adequate protection to the community at large. There's one other dimension that I might mention here that you alluded to in the international scope of this problem. From the beginning, it has been a global problem. And the global response is a critical part of controlling ultimately and living with the coronavirus epidemic, pandemic in the future. It is very evident that a critical part of this is vaccination around the world, immunization around the world. And it is a missed opportunity, in my opinion, for US leadership in the world not to step up more aggressively to meeting the global need for immunization against COVID. We've heard many times from our leaders that the US has supplied more vaccine than any other country to other countries around the world. And that is true. And that is insufficient. When the AIDS pandemic was raging around the world, President Bush did not say, we're producing more antivirals for HIV than anybody else, and it's available in the world. The United States mounted the PEPFAR program, which was designed expressly to treat every person infected with HIV in the world, especially focused in Africa. We need a similar vision today, where the United States steps up to the challenge, not of doing more than anyone else, but of solving the global problem and mobilizing others, both allies and others who could be brought to bear in a concerted way to solve this global problem. This is an opportunity that still could be seized, and it's an opportunity that the United States should take.
So, Harvey, you've talked about what we're going to need for the next pandemic. Can you give an example of an area where we can't rely on what we've always done in the past, where we need something new?
You know, the same data systems that our public health authorities may rely upon to count the number of people with stroke or myocardial infarction over time are really not up to the task of real-time tracking and monitoring a fast-moving pandemic. And the idea that for the last 2 years, we have relied more on sources such as the Atlantic or the New York Times or a number of very reputable universities to provide the most current and accurate information rather than the Centers for Disease Control and Prevention, which has been in the position of certifying the data weeks to months later. This is a real challenge for future capacity to respond to a pandemic. This is an illustration of that shift from business as usual to business in response to real-time needs. And agencies of government at all levels, just as clinicians working in our hospitals and public health authorities working in our local and states, all need to be prepared to respond up to the task, not in the way that has been customary in the past.
It's admittedly very difficult in a political system such as ours to make complicated choices under time pressure and based on sometimes highly technical information. But given that, what lessons do you see here for the next pandemic?
The first lesson for me is that planning is not the same as preparedness. You can have a lot of plans, but if you haven't put them to the test, if you haven't actually done the mock mobilizations, if you haven't run the exercises, if you haven't looked at all the contingencies, and if you haven't adopted an attitude of flexible adaptation to conditions as they change, you're not really prepared. That's number one. Number two, we do in the United States have to face up to our differences in the federal system of authority at the state and the federal levels. We just had a Supreme Court decision about the limitations of authority of the president and the Occupational Safety and Health Administration to issue requirements for immunization. We need to be prepared with legislation and not rely simply on executive action to be able to respond in a way that is up to the task and still preserves the degree of individual freedom that the United States stands for and that we cherish as long as the public safety can be protected along with that. The third thing is that we cannot simply adopt a crisis mode of response. We have to make the infrastructure, long-term, continuing investments that lead us to be prepared. It's remarkable to me that while every hospital in the United States that gets funding from the federal government must be accredited as an institution that has the required structural programs, staffing, capacities to provide adequate care, we do not have the same requirements for departments of public health, county by county. There's voluntary systems of accreditation. We should have a national system that lays out for every county commissioner, every mayor, every governor, what the core requirements are for a sufficient public health capacity at the State Department and at the county and local levels. And we ought to grade and make those public and let the people know where they are up to the task and where they fall short. And then finally, we need to have the capacity of leadership that can simultaneously rely on science and the best evidence and recognize when business as usual is no longer up to the task. If we put those elements in place, along with the other things that we've been discussing on scientific learning capacity and leadership, this will give the United States a much stronger foundation for responding effectively over time to new pandemics, and there will be new pandemics. We will be facing those inevitably in the future as we have in the past.
Harvey, let me focus on one of your points, which is the idea of professionalizing public health. I mean, certainly this is no criticism of the people who were working in public health, because there are a huge number of very dedicated people who have prepared themselves for these jobs by studying at schools of public health, like the one that you used to lead. And yet, as you say, there is not only a lack of standardization, but there's extreme decentralization, so that every single town, every single county has their own public health service, none of whom can have a breadth of experience simply because of numbers. They simply don't see that many things. And in some ways, it's comparable to a very small clinic versus a large academic hospital, where not everyone should be doing everything. But right now, it seems to me we are asking every individual public health community to be doing everything. It seems unfair.
I celebrate the achievements of our public health professionals and leaders, and it has been at its best truly astounding and remarkable and successful. You put your finger, Eric, on a very important point, which is both the variability in capacity and preparedness and the lack of a systematic differentiation of where responsibility and capacity resides. That's why the kind of system of review and accreditation that I'm talking about would look specifically at the scope of a population, the span of responsibility, the level of authority that would be required to carry out those responsibilities at a state, a county, a municipal, and a local level, and would also look at the relations at the state level to national authorities. So it's not that everyone would be doing and expected to do the same thing. The reason now there may be confusion about, well, everything is going to fall back to the local authority, as you described, is that there's not clarity about where the responsibilities reside within each jurisdiction. And if we had that clarity, and we had the measures, and we had, if you will, the rating system and the public understanding of that, we would simultaneously be rewarding and celebrating those public health professionals and teams that have done the right thing, and we would be pointing out the needs for improvement where there are shortcomings. So I see the mechanism of looking more critically and in an accreditation process as responding to the confusing distribution of responsibility that you're alluding to, as well as rewarding and recognizing excellence in the public health professions.
Harvey, you also highlighted the importance of communication. And I worry a little bit as we witness the politicalization of information, with erosion of what a fact is, and the speed with which an observation is made and then shared globally to everyone almost the same day before it's been verified or expanded upon or fully understood, has created incredible challenges in how we communicate what we think is going on and therefore what the response should be. How should we guide this process in the modern information age and how we communicate?
Lindsey, you say you're a little worried. I'm a lot worried about it. It is a very serious challenge to sensible decision making for individuals as well as for policymakers and clinicians as well as public health authorities. The profusion of non-facts, the level of distortion, the willingness of individuals or groups for nefarious or distorted purposes to purposefully mislead or to raise levels of fear or to disregard the factual evidence. These are very, very serious problems. I think that's why voices such as the New England Journal of Medicine and other authoritative sources become ever more important in the world of profusion of information even than they were in the now older world of slower, more, let's say, well considered distribution of knowledge. It does mean that places like the New England Journal need to be more nimble, need to be more ready to be on top of current information, need to be able to differentiate the degree of confidence that one can have in evidence as it emerges, to bring forward the kinds of qualifications that you and Eric talked about when you were describing the studies in the current issue. All of this, if you could amplify through other authoritative voices, would be the strongest neutralizer to the acid of misinformation that proliferates today in the social media, the World Wide Web, and in many other channels of communication. This is not a simple problem to fix, but it is a very real challenge to those of us who believe in the importance of evidence and science as a guide to sensible decision making.
Thank you very much, Harvey, for joining us today. And as always, thank you, Eric, and thank you, Lindsey.